Most of us chalk up gritty eyes, a sticky mouth, and nagging joint aches to just getting older, never suspecting that those everyday annoyances could be the earliest cries for help from a much more serious problem. Sjögren's syndrome, an autoimmune disorder that prompts the body to attack its own moisture-producing glands, and far more, affects an estimated 4 million Americans. Yet the average patient wanders from doctor to doctor for roughly 4 years before anyone puts the pieces together. That diagnostic detour steals quality time, lets damage accumulate, and raises the odds of dangerous complications that could have been slowed or even avoided had the warning signs been recognized in the beginning. Because those signs often masquerade as ordinary inconveniences, many people shrug them off, pop an artificial teardrop, or sip an extra glass of water and move on. Doing so, however, can allow silent inflammation to smolder in joints, nerves, lungs, kidneys, and even the heart. By the time the real culprit is spotted, those organs may have suffered wounds that never completely heal. Learning what subtle clues point toward Sjögren's and acting when they appear can change that story. What follows weaves 8 of the most important early indicators into one coherent picture, explains the science behind each, and shows why none of them should be dismissed as harmless. First, the eyes. Everyone experiences dryness after hours at a computer or exposure to dusty wind, but Sjögren's dryness feels different. It is relentless, as though someone swapped your natural tears for sandpaper. The immune system targets the lacrimal glands in the upper outer eyelid, the factories that create the watery layer of the tear film. When those glands sputter, blinking no longer sweeps a smooth, nourishing coat across the cornea. Instead, each blink drags over a rough surface. Patients describe a grainy irritation that refuses to clear, eyelids that stick to the globe upon waking, or light that suddenly seems too bright. Sometimes vision blurs, not because the prescription changed, but because the tear film, nature's first lens, is patchy. Eye care professionals use a Schirmer strip test, slipping a tiny piece of filter paper under the lower lid for 5 minutes. Less than 10 millimeters of moisture on that paper strongly suggests tear deficiency. Ignoring that gritty feeling means micro-abrasions can develop, infections can gain entry, and scar tissue can form, permanently clouding sight. Next comes the mouth. Saliva bathes teeth in minerals, flushes bacteria, starts the digestive cascade, and lets us taste subtle flavors. When Sjögren's driven inflammation scars the parotid and submandibular glands, the tongue sticks to the palate, breadcrumbs cling stubbornly to molars, and speaking for more than a few minutes feels like talking through cotton. People compensate by carrying water everywhere or sucking hard candies all day, a habit that disguises the seriousness of the problem while bathing enamel in sugar. Cavities erupt where dentists rarely see them, along root surfaces and at the gum line, and oral thrush paints the cheeks with white patches that sting. Some sufferers develop burning mouth syndrome, a searing sensation on the tongue or lips that has no obvious physical cause but is almost unbearable. Because dentists are often the first to spot the telltale pattern of decay and salivary swelling, routine cleanings become frontline defense against delayed diagnosis. While the tear and saliva glands bear the brunt, Sjögren's rarely confines itself to them. Many patients discover the disease through the nervous system's complaints. Tingling, prickling, or burning that creeps in from toes or fingertips, called peripheral neuropathy, can emerge months before dryness is severe enough to mention. These sensations follow a glove and stocking distribution because the smallest nerves starve first when inflammation throttles their blood supply. Conventional nerve conduction studies may look normal. Only specialized skin fiber biopsies reveal the damage. At the same time, an unsettling mental haze settles over daily life. People fumble for common words, lose their train of thought mid-sentence, or reread the same paragraph without comprehension. This so-called brain fog is not laziness or depression. Magnetic resonance imaging sometimes shows tiny white matter lesions that mimic multiple sclerosis and fool inexperienced clinicians. Migraine-like headaches join the chorus, often resistant to usual pain relievers until the underlying autoimmune flare is tamed. In rare but dramatic cases, inflammation strikes the spinal cord, transverse myelitis, producing sudden leg weakness or bladder paralysis that demands emergency steroids to prevent irreversible paralysis. The heart can become an unsuspected battleground. Chronic systemic inflammation roughens arterial walls, inviting plaques to form earlier than age and cholesterol alone would predict. Some patients develop pericarditis, an inflamed sac around the heart that causes stabbing chest pain, relieved only by leaning forward. Others experience unexplained palpitations as immune cells infiltrate the conduction system. Vasculitis, the swelling of small blood vessels, restricts oxygen supply to heart tissue, triggering exertional shortness of breath or silent ischemia. These cardiac expressions are easy to mislabel as anxiety or deconditioning, especially in postmenopausal women whose atypical symptoms already challenge standard cardiac algorithms. Recognizing the link between an autoimmune flare and chest discomfort can guide cardiologists toward anti-inflammatory therapy alongside the usual heart drugs, protecting muscle that might otherwise scar. Joints and muscles raise their own red flags. Unlike rheumatoid arthritis, Sjögren seldom erodes bone, so X-rays often appear normal even when pain is intense. Stiffness greets the morning, locking fingers and wrists for an hour or more until motion acts like oil on rusty hinges. Symmetry provides a clue. If both knees ache equally and both ankles swell by evening, think inflammation rather than simple strain. At night, deep aching in thighs or shoulders disrupts sleep, and the exhaustion that follows worsens cognitive fog. Exercise, paradoxically, becomes both remedy and obstacle. Too little movement lets muscles decondition, but too much triggers post-exertional malaise lasting days. Finding the sweet spot of gentle, regular activity eases pain and preserves strength, yet patients can do that only after someone names the cause. Lungs, quietly vulnerable, develop subtle interstitial inflammation. A breath that once climbed a flight of stairs with ease now leaves a person pausing halfway, chalked up to aging or pandemic-era weight gain. A dry cough nags during phone conversations or at bedtime. High-resolution CT scans reveal wispy fibrosis long before plain chest X-rays show trouble. Pulmonary function tests record a restrictive pattern, lungs that cannot fully expand, as scarring stiffens tissue. Left unchecked, interstitial lung disease can advance to oxygen dependence. Early immunomodulatory treatment, however, can freeze progression and preserve precious respiratory capacity. The kidneys filter blood around the clock, yet Sjögren's interstitial nephritis can silently erode their efficiency. Clues appear in subtle laboratory shifts: a slight rise in creatinine, mild metabolic acidosis, or persistent low potassium that causes muscle cramps and palpitations. Patients may notice nocturia, multiple trips to the bathroom each night that fragment sleep. Catching renal involvement early allows doctors to adjust medications, prescribe alkali therapy, and monitor for stones before pain brings someone to the emergency room. Finally, the blood itself holds secrets. A routine complete blood count may show mild anemia from chronic inflammation, low white cells that leave a person vulnerable to infections, or reduced platelets that cause easy bruising. Elevated gamma globulins hint at immune hyperactivity. Most sobering long-standing Sjögren's multiplies the risk of non-Hodgkin lymphoma, particularly when salivary or parotid glands stay swollen, night sweats develop, or unexplained weight falls away. Regular lab panels and vigilant self-observation for new lumps or drenching sweats become life-saving habits. Pulling these disparate symptoms together into a single diagnosis requires persistence from patient and clinician alike. Because every individual displays a unique subset, the constellation may not line up clearly on the first visit. Yet awareness of the possibility shortens the hunt. Rheumatologists use antibody tests, anti-SSA, anti-SSB, rheumatoid factor, along with objective dryness measures and sometimes salivary gland biopsies to confirm the puzzle. Once identified, treatment is two-pronged: topical relief for dryness, prescription tear stimulants, saliva substitutes, punctal plugs, and systemic immunomodulators like hydroxychloroquine, low-dose steroids, or newer biologics to quiet the rogue immune attack. Lifestyle adjustments round out the plan: rigorous dental hygiene with fluoride varnish, humidifiers at night, polarized sunglasses outdoors, scheduled rest breaks to combat fatigue, and tailored exercise that strengthens without triggering flares. The earlier those measures begin, the more gland tissue can be spared from permanent destruction, and the less collateral damage accumulates in nerves, lungs, and kidneys. So if your eyes itch relentlessly, your tongue clings to the roof of your mouth despite good hydration, your fingertips tingle for no clear reason, or symmetrical joint pain greets you every dawn, push for answers. These signs may be mundane on their own, yet together they whisper the name Sjögren's long before a crisis shouts it. Listening to that whisper, seeking evaluation and demanding comprehensive testing can transform an exhausting mystery into a manageable condition. In the realm of autoimmunity, knowledge truly is the most powerful medicine, one that buys back energy, preserves vision and teeth, safeguards organs, and lets people live fully rather than merely endure.